Good afternoon, everybody. I'm delighted to be here today to give a slightly different perspective on data and how it can be used for clinical audit. The Irish Hip Fracture Database in particular is quite relevant today as it's housed in the HYPE system within the hospital. And I want to give a special mention to Phil Dunn, who isn't here today, but he works in the Healthcare Pricing Office, and he certainly has enabled the Hip Fracture Database to become what it has today. So a huge thank you to Phil and the team in the HPO. So what is clinical audit? Essentially, it's a clinically led quality improvement process that seeks to improve patient care and outcomes. There has to be clearly defined standards to measure against, and the most important thing is to improve care where standards are not being met. So that is essentially the mantra of the Hip Fracture Database. We've heard hip fractures mentioned several times today already, and I suppose I'm going to try and elaborate as to why hip fractures are a particularly good condition to audit. So the majority of hip fracture patients are older patients. The average age is over 80 now. And as Colm Henry mentioned earlier, people are living longer, but they're living longer with more conditions, which means when they break their hip at the age of 80 and come into our hospitals, it's much more challenging for us to then care for them. It's a very clearly defined diagnosis. Usually the hip is either broken or it's not. So there's very little ambiguity about the condition itself. We've got really good evidence as well for how we should care for hip fracture patients. And this has come from our international colleagues who've been doing this a little bit longer than us. We know that care is complex and costly, and that is how, I suppose, my first interaction with Maureen happened. We started looking at hip fractures and how care varies. And I'll talk a little bit later on about what we've been doing over the last while. We know that care outcomes and costs vary from site to site. We have 16 trauma hospitals in Ireland, and there's huge variance in how hip fracture patients are cared for, despite the small number of hospitals. We also know that the numbers are rising. We can't get away from this. Our population is aging, and our old population in particular are almost going to triple in the next 20 years. So we're going to be seeing lots more hip fractures unless we try to do something now to prevent them. So this year, or last year, in 2016, that should say, we had 3,610 hip fractures in Ireland at a very crudely estimated cost of 45 million just for the inpatient care. And this is, I suppose, one of the reasons hip fractures make a very good condition to audit, because they come in contact with nearly every discipline in a hospital. They take up an awful lot of resources, and coordinating that care in some sort of a clear pathway is very challenging. So to date, the Irish Hip Fracture Database has published 3 national reports, and we're due to publish our next report later on this year. Colm showed this slide earlier on, and I apologise that the writing is quite small, but essentially we have 6 gold standards for hip fracture care, and that is, I suppose, the essence of the hip fracture database. So some of the standards relate to timing, getting them through the ED quickly, getting them their surgery quickly, preventing pressure ulcers, ensuring that they're seen by a geriatrician, and making sure that they have a falls assessment and their bone health addressed. So to date, this slide shows the number of patients who had additional hip fracture data entered on the HYPE portal. So in 2015, 81%, and I'm happy to see that in 2016 we've captured data on 86.5% of all cases. And this is being done by nurses primarily in the orthopaedic departments around the country, and a lot of them have taken this on extra to their work because they're quite passionate about improving hip fracture care. So we're very appreciative for all the hard work that goes into collecting this data. The completeness refers to how much data has been entered per individual case. So the amount of data being entered is excellent. It's over 96% consistently. So this is how we enter our data. We use the HYPE portal, which is very accessible to nurses or data coordinators on the ground. It's accessible on any HSE computer. And we have an individual login and password, and the clinical lead, who's usually an orthopedic surgeon or a geriatrician in the hospital, has also a password and a logon. Rather than duplicate information, the demographic data that's already recorded on HYPE and the admission source are automatically migrated into our data set. So we don't have to duplicate anything. And then we start entering our clinical data, which essentially is the pathway from the point of admission to discharge through the portal. Phil has also, over the last number of years, develop the portal further. So you can see there's a number of different reports available to us at a local level, which are hugely useful, and that's what drives the majority of the quality improvement at a local level, is being able to give this information right back to the clinical team that need it on the ground. So I was going to just present a little bit of the data from the 2015 report, just to show the value of having this information and what it's doing for clinical people on the ground to improve care of hip fracture patients. So 70% of our hip fractures are female. And as you can see there, the majority of patients are old, so over 80 years of age. And we've a growing number of over 90s now coming through over the last number of years. The majority of hip fracture patients come in from home, and when you look at the outcomes of hip fracture patients, you'll see that less than half of these people will get back home. 33% of them will die within 12 months of their hip fracture, and a big majority of them will require lots of extra care at home and in the community in order to manage on a day-to-day basis. So there's huge costs associated with hip fractures long after they've left the acute hospital as well. About half of these patients were independently mobile, so they're quite good 80, 90-something-year-olds walking around. The types of fracture, this is more relevant to our orthopedic colleagues, but basically, depending on where the fracture is in the hip, the fixation that's suitable varies. And depending on the fixation, whether or not they can get back walking, fully weight-bearing immediately after surgery, varies as well. And if you can't get back on your feet after a hip fracture, your mortality goes up, your outcomes go sky high, and a lot of these people won't do very well. So the idea is to fix the hip fracture so that they can weight bear almost immediately on it and get back on their feet. This slide is particularly relevant as well. I think Dr. Henry's gone now, but we've been using this information nationally to look at there's still about 11% of hip fracture patients being brought indirectly into our operating hospitals. So in particular, this happens in the southeast, where I work. If you break your hip in Kilkenny, up to quite recently, you would be brought into Kilkenny Hospital first, where there's no orthopedic service, and then you get put back in an ambulance and brought down the road to Waterford, which does nobody any good, and it just delays the inevitable. So based on the data from last year's report, we've now brought in bypass in the southeast region and up in Cavan as well. So the hip fractures are bypassing Cavan and going straight to Connolly Hospital and then being repatriated back to Cavan once their hips are fixed. So this is really powerful and really beneficial for the patients who have hip fractures in these areas. Time to surgery is very significant for hip fractures. So for every 8 hours you delay a hip fracture going to surgery, it adds 1 day onto their length of stay. So for every day, you can add 3 days onto their length of stay. There's a national key performance indicator around timing to surgery, which stipulates that 95% of our hip fractures should have surgery within 48 hours. That's an international best practice standard as well. So currently in Ireland, only 72% of our hip fractures are having their surgery within 48 hours. And what happens after the 48 hours is an exponential increase in mortality and poorer outcomes. One of the key things we need, and we'll be leveraging as much as we possibly can from our data, is the input from geriatricians, in particular orthogeriatricians, into this cohort of patients, because essentially they're the best people to care for them. Once the fracture is fixed, the majority of their care is medically based. So in the UK, they have a model where geriatricians and orthopods either share care or the geriatricians will take over the care after the orthopods are finished. But either way, the input of a geriatrician early in this group of patients has huge benefits in terms of mortality, getting them home again, and functional outcomes. So to date, at the moment, only 15% of our patients are being seen preoperatively by a geriatrician, and most of this is being done by interested geriatricians who locally are trying to see these patients, but the resources need to be put in place to run a permanent service where our geriatricians will come by routinely and see these patients all the time. We have seen a big improvement in the volume of geriatrician input over the last year or two, but we really badly need ortho-geriatricians in all of our orthopaedic services around the country. So that's something that's starting to happen. There's been 1 or 2 posts advertised this year already, so we're very happy to see that that's going to be the case. The different ways fractures are fixed. This information is obviously very relevant to orthopaedic surgeons, but again, it allows us to see, is the right surgery being done for the right fracture? Are patients having the right implants put in? And as you probably know, implants vary in cost hugely. So this is something we'll be able to drill down more into over the next few years to make sure that we're utilising the resources we have properly as well, and giving the patients, most importantly, the best chance to get back on their feet and get home again. I apologise, this slide is a little bit cut off, but essentially, I mentioned earlier, getting people back on their feet is the key thing to getting these people home and well again. And currently, we only have 7 hospitals out of the 16 that offer 7-day physiotherapy in the orthopaedic departments. The trauma happens 24/7. Hip fracture patients come in 24/7, but we staff our hospitals Monday to Friday, essentially. So if you have your hip fracture fixed on a Friday, it's very possible that you won't be seen by a physiotherapist until Monday. And that's a huge loss in terms of functional gains for that patient. That probably won't be regained. So again, it can have devastating consequences for these patients. Pressure ulcers. It's the only nursing care indicator currently in the database, but it's a very important one because on top of the already added morbidity and mortality of having a hip fracture, having a pressure ulcer on top of that, again, just makes things all the more worse. And hip fracture patients are particularly susceptible because they become acutely immobile when they break their hip. They're then put in a bed and kept still and fasted and put in theatre, and they're not mobile for several days at least until after their surgery, and they're just a sitting duck essentially for pressure ulcers. So we are very vigilant in screening for pressure ulcers. And currently, we have a kind of a consistent 4% pressure ulcer rate nationally. Actually, just before I move on, so the other side of using the database is that, and in more recent times, there's an increasing interest in using this data further for research. So Professor Zena Moore in the Royal College of Surgeons, is going to conduct a study on pressure ulcer incidence in Irish hip fracture patients to see, can we further stratify which group of hip fracture patients are more susceptible? Is it the older old? Is it the people who are being delayed? All these things. So again, we can feed that information back to the hospitals and help them improve the services and care that they're delivering. Bone health assessment. So by the virtue of the majority of these patients just falling over and easily breaking their hip, we can assume that their bones are pretty frail and not as strong as they should be. So nearly all of these patients should be put on treatment to make their bones stronger. And as you can see, only 34% of our hip fracture patients are currently being put on something to protect their bones, despite having a devastating fracture. And this is primarily down to the fact, again, that we don't have geriatricians involved. Geriatricians generally provide a very holistic care to this group of patients. So they would look at their bones, they'd look at their falls, they'd look at everything. So I suppose as we see geriatrician involvement increasing, we should also see this standard increase massively as well. And same applies for falls assessment. So 95% of hip fractures are caused by older people just falling over from standing height. So we need to determine the cause of these falls in order to prevent further falls. And at the moment, less than 50% are having their falls assessment. So again, we're using this as a mechanism to drive the need for further geriatrician support in our hospitals. Our length of stay at the moment, the average length of stay is 20 days with a median of 13 days. So these patients are in the hospitals for quite a long length of time when they're in with us, which makes them very vulnerable to picking up lots of other things along the way. In 2015, we made 3 key recommendations in the national report. I mentioned earlier about the hip fracture bypass, but that's key. In this day and age, we shouldn't be bringing patients to hospitals that don't have a service they require. It's just delaying the inevitable. So as I mentioned, the bypass is now up and running in the southeast and for Cavan, and that will cover the majority of the bypass issue to a large degree. We also recommend that 100% of this data should be facilitated in the hospitals. So we're encouraging hospital managers to now support the data coordinators and give them protected time, because the value of this data is critical to achieving good outcomes for these patients. And we also advocate that in each of the hospitals there is a group of multidisciplinary stakeholders involved in hip fracture care looking at this data on a regular basis and benchmarking themselves against earlier performance and against national performance and best practice standards. Phil sends monthly reports to myself in the National Office of Clinical Audit, and it just helps me coordinate the data inputting in the local hospitals. So for example, if we know someone is struggling to get their data in, we can contact them and offer them support. But you'll see the 6 columns there, standard 1 to 6. This is something that we've been looking at for the last probably year or so now, following a meeting with Maureen. If there was ever going to be a case whereby we would pay an extra tariff or an incentive for providing best practice care, we're just looking to see how many of our hospitals would currently meet the 6 standards. So what you can see there on the bottom is, in 2016, only 20 patients out of the 3,600 and however many met the 6 standards of care. And this is, again, largely down to lack of geriatrician input, theatre closures, not having 7-day access, all these things. So we're just going to keep an eye to that, and hopefully as our data collection continues to improve, we can explore this further. But either way, just by measuring the data and feeding back regularly to the hospitals, the care does improve. This is just an example of the quarterly reports we now send to the hospitals. This goes to the hospital managers, clinical directors, clinical leads, and we also now send them to the groups as well. And it's very succinct and it's very helpful, we find, at a local level to show how the hospital is doing in terms of its coverage and each of the 6 standards. So if anybody has any questions, I'm more than happy to be contacted at any stage. There's some copies of the hip fracture database report just around the corner here with the stands. And I suppose most importantly, if everyone could take this message home today, looking after hip fracture patients well is a lot cheaper than looking after them badly. Thank you.